So here's the classic way to look at deformity analysis, which really comes from Dror Paley. I think Dror did an amazing job early in his career, and Kevin Tetzworth helped him, and Anil Bahave put together this treatise on how to analyze deformity so that you can even attempt to correct. And it's very geometric. It's completely radiograph based. Right, so you'll take an X-ray, you'll see the bone, you'll measure what's normal and what's not normal. But we need parameters based on population average norms to figure out what is normal and where's our deformity localized, and are we missing something, particularly in congenital deformities where there can be quote hidden deformities or growth plate disturbance deformities where there's some subtlety to the deformity. So this is a classic frontal view of the normal joint orientation angles. So the point of this is not to memorize these angles right now, but we all know these angles. If you quizzed us, we could tell you the numbers here. The lateral proximal femoral angle is this proximal one here. That's used not so commonly in an everyday practice, but once in a while you will get a proximal femoral deformity and need to understand what's normal, what's not normal. And this is a mechanical one, right? There's also a neck shaft angle, which isn't listed here, but neck shaft angle is more utilitarian, I'd say, and easy to talk to your colleagues about. Lateral distal femoral angle. This shows that the knee joint has a little bit of a tilt to it at 3 degrees, right? It's not perpendicular to the floor. It's actually 3 degrees tilted. So we have 88 degrees, so 2 degrees tilted in this example, or 87 degrees would be normal. And the normal range is here. Medial proximal tibial angle, MPTA, at 87. Again, these ranges are from 85 to 90, and that's based on population average. Distal tibia is lateral distal tibial angle, and that's around 90 degrees, so it can be from 86 to 92 degrees. So these are workhorse angles we use daily to analyze long-standing X-rays. So we speak this language on a daily basis. So before you attempt to take on a deformity patient, you really kind of need to know these things. Then there's the sagittal plane, right? So this would be your lateral X-ray. And in this hospital, you can get a full-length lateral X-ray with the knee full extension or not full extension. And again, the workhorse angles would be the angle of the sagittal plane of the femur and the sagittal plane of the tibia proximally. The tibia distally for the femur, and then also at the ankle level. So we have the PDFA, 83 degrees, PPTA, 81 degrees. That's your 9-degree tibial slope, right? So sports guys will talk about the slope. Is it high slope, low slope? We speak about it in a different language, saying what is the angle compared to the long axis of the tibia. So if we said there was no slope, that would be a PPTA of 0 or 90. Sorry, PPTA of 90 would be a 0 slope. A 9-degree slope would be 81 degrees PPTA. And then there's 80 TA, so that the ankle is actually tilted up 10 degrees as well. And this is helpful, say, a bone transport case where your distal tibia is 2 centimeters of bone. How do you orient that correctly when you go to dock it, right? So you need to know that your ring has to be 10 degrees off from the orientation of the joint. So it's a very important number to keep in mind. And this lecture typically just goes through his whole first 3 chapters of the book and talks about that. I'm going to do it a slightly different way. So here's mechanical axis, another really important name you need to know, and what this means. It's basically a line drawn from the center of the femoral head to the center of the ankle. And again, it's a workhorse measurement for research and for basic deformity planning. What's your mechanical axis? Is it medially deviated for bow leg? Is it laterally deviated for valgus or knock knee? And what is the norm? We tend to say that 0 is the norm, but the truth is that 0 to slightly medial is the norm. There's a range of norm, and this is kind of that range right here. Okay, so let's look at some examples because that's more fun, right? So, a patient comes into your office and you need to analyze their deformity. Well, here's a patient who has an infected distal femur nonunion. Okay, fine. We're not really going to talk about that, other than the point is there are still indications for external fixation. And a ring fixator on the femur still is a good option for some people. And we can rid the infection, so we can eradicate infection and get the bone to heal using that mode. But let's get to limb deformity analysis. So he's left with a leg length discrepancy, right? We cut out the dead bone. We got him to heal. He's actually pretty well aligned. His mechanical axis goes to the middle of his knee, and it's the same as the other side. If we draw a line from the center of the head to the center of the ankle, that's mechanical axis, right? So you hear that word again. Let's look at leg length. So this is trauma, right? So he shouldn't have any congenital leg length discrepancies. So his tibias should be the same length. His feet should be the same heights, right? There really shouldn't be an issue there. He did have a little trauma to the tibia, so maybe that's not true, but it actually measures out to be true. So if we look at his mechanical axis and turn that into a direct leg length measurement, so we're measuring from the top of the hip to the ankle joint line. So hip joint line, ankle joint line, that's going to be his leg length, right? And we compare the two sides and there's a difference. So that's called the direct leg length discrepancy. And his direct leg length discrepancy is simply those two measurements, the difference. The difference is 58 millimeters. So his left side is 58 millimeters shorter than his right. And presumably that's all in the femur, right? We can also do an indirect. So the problem with the direct is if there is a discrepancy in the in the foot, if you got a calcaneus fracture that flattened his calc, if he's got a flat foot, if the foot's congenitally smaller, if there's any deformity outside the hip to ankle range, then we miss it. We miss that component of leg length. And in some cases, there'll be a short pelvis on one side compared to the other in a hemiatrophy or hemihypertrophy situation. So we want to take all that into account. So it gets a little more complicated when you look at indirect leg length discrepancy. In this case, we'll measure indirect leg length from the top of the hips to the top of the x-ray. Actually, x-ray, the top of the x-ray is actually a very good level surface, right? If you don't trust that line, it looks off, you can draw a level. You can take a level plumb line and just put it up top and measure that distance. And that's everything from the hips to the floor, right? So we're going past the ankle, going to the floor, we're doing that measurement. So that's the indirect, right? So it's called, that's our terminology. So it's going to be the block the guy's standing on, plus any difference in the heights of the hips, right? So in order for us to clinically figure out leg length discrepancy, we put a block under the short leg and try and level the pelvis. So in this case, we put a 50 millimeter block under the left foot, said that looks pretty level. And then we got an x-ray and showed it was not quite enough. We were 6 millimeters off. He needed 6 more millimeters. So the difference is the block, right, which almost leveled them out, but you can see that the left side's still a little lower. The distance from the top of the x-ray is a little higher. And therefore, we should have had a little bit bigger block. We were 6 millimeters off. So it's actually 56 millimeters. These two numbers are extremely close and essentially the same. It's probably measurement error. So we're going to say that he has, leg length discrepancy somewhere between 56 and 58 millimeters, and it's coming from his femur. And then that's, as Chris showed, basically a chip shot, right? We just insert an antegrade femoral nail, slow lengthening in a patient who's post-traumatic. He did have a history of infection, which was a question from the audience before, the virtual audience. How do you deal with this in an infection? But the infection was down here. So I just don't put my nail down there, right? I stay away from the infected zone. He never got another infection. He was fine. And eventually you get the nail out because technically it's contaminated. If it went into a zone even close to an infection, you don't want to leave it in there too long. Okay, let's analyze another deformity. So let's add another level of sophistication to this. Leg length discrepancy and deformity. Okay. So we kind of looked at mechanical axis. We get that his mechanical axis normally, this is his normal side, is 7 medial. Okay, so for him, that's where he lives. And the other side, he's 13 lateral. So he has a valgus deformity of the right lower extremity. Okay, and it's around the level of the knee because that's where you see mechanical axis deviations. Otherwise, the femur looks pretty straight. He also has a leg length discrepancy, right? So basically there was a attempt to activate a sleeper nail, which ended in an extremely slow regenerate with an extremely slow lengthening at 0.5 millimeter, 0.15 millimeters a day, and still took forever to heal. So we wanted to lengthen somewhere else. And he has a valgus deformity. But let's analyze the deformity. Let's analyze the leg length. So if you do a direct measurement, that would be this number, hip to ankle, the difference is 46 millimeters. So his residual length discrepancy is 46 millimeters. If we put a block under him, you can see we put a 4 centimeter block under his right foot. And you can see that if we draw a line from the hip to the top of the screen, it's still longer. So it's still like not enough block. So we should have added more block. 4 more millimeters would have evened them out and pushed that right side up to meet the left. So it's the block plus the difference, 44 millimeters. Again, these numbers are really close. So it's about 44 to 46 millimeter leg length discrepancy. So you could lengthen 44, get another long film, and then assess whether you think that it's level or not, or whether it needs a little bit more. In theory, that's a way to do it. So meanwhile, we also have this deformity now, right? So I can't just put another nail in and lengthen him. I have this deformity to deal with. So let's look at our deformity analysis. So we look at LDFA, MPTA, side to side. LDFA is the same on both sides. So actually his femur is not deformed. There is no valgus of the femur. His tibia, interestingly, is also really, well, let's look. On the normal side, it's 86, and on this side, it's 92. So it's actually a tibial deformity. So I have the option of saying, well, I'm going to break his tibia and correct valgus to the tibia, and I'm going to do a retrograde nail lengthening and get the leg length discrepancy fixed to the femur. Or I can do what Chris just talked about and do a distal femoral osteotomy, kick the femur into neutral alignment, fix the mechanical axis, even though it's technically normal, and then lengthen through that. And that's going to be one osteotomy, and we're going to leave his tibia alone. And I think there's some value in that. So this is where the adult in the room has to override the dogma and say, this makes sense, we're doing that, So you plan out your retrograde nail correction, and I switched the nails out and did an acute correction to the valgus and lengthening to equalize the leg lengths to get him to equal leg lengths. So this is the publication that Chris showed earlier that was a great multi-center collaboration that he initiated, and good job with him. Okay, so deformity nonsymmetric. So this is a great case to show that you really do need to go through the mechanical axis analysis and the joint orientation analysis. So patient comes to me, says he has pain in his medial aspect of his knees, he's already in his 50s, and he wants his bow legs corrected, right? So you just look at the x-ray and you're like, okay, he's got bow legs. He probably has tibia vera on both sides. We'll correct both tibias, right? But when you actually do the work, first of all, you see there's a leg length discrepancy of 21 millimeters. And he said, oh yeah, I don't wear a lift and my back hurts a lot, So, okay. So there's a leg length discrepancy. Again, we look at the direct number. Hip to ankle is 21. We can do an indirect measurement, but that ends up showing the same thing. We look at the breakdown analysis of the actual joint orientation angles, and this gets much more interesting. So look at his LDFA. It's 97, right? Normal is 85 to 90. So he's got a varus of his femur on this side. And look at his MPTA, it's 87. So it's actually not a tibia deformity on the right. On the left, it is a tibia deformity. His LDFA is 91, which is essentially normal to 1 degree above normal. And the tibia though is 81. So this is like, it's flip-flopped, right? It's femur varus on one side, tibia varus on the other side. So if you didn't do your due diligence, then you would have ended up putting this tibia at 97. So you'd have 97, 97, oblique joint line, suboptimal. Plus he's got a leg length discrepancy, and who wants to lengthen the tibia instead of a femur, right? Femurs are so much easier to lengthen. We didn't talk about that much, but femurs are way easier to lengthen than tibias for about 10 reasons. So this is actually super interesting. So I can attack the tibia on this side and get a normal joint line at 91, 91. And I can attack the femur on this side, again, doing the retrograde nail with the acute correction, leg length equalization using the lengthening nail, and get a normal mechanical axis and deliver a normal joint line at 87, 87. So it's really important to break down these analyses. We've done a lot on varus correction. We have every flavor of possible way of correcting varus. We've figured it out. Let's look at a rotational deformity. I think that this is a really interesting topic. And I think that Mitch might be talking about this a little bit, but it's super important to understand how to use CT version to understand rotational deformity. Here's a 23-year-old who had obviously healthy young woman, bilateral femur fractures. And her complaint was that her knee wasn't working right and that she couldn't straighten it all the way. So there's a little bit of a procurvatum sagittal deformity here. Okay, the nail didn't go in perfectly straight. They should have used a blocking screw. Overall, it looks pretty good from a coronal plane. It doesn't look like it's in varus or valgus. But when you do her CT version, here's the side that isn't quote normal. Now we don't know what normal is because she has bilateral nails, but in this case, we look at the CT version, and this falls within the normal anteversion. So if we subtract 8 from 19, right, we're getting the orientation of the femoral neck versus the posterior femoral condyle. We get 10 anteversion. So the femoral head is 10 degrees essentially externally rotated compared to the distal femur. So we have 10-degree anteversion. You look at the other side, you can see the femoral neck is actually pointing posterior compared to the femoral condyles. She's 18 degrees retroverted. So when you say how off is she, she's actually the sum of that, right? Because she's 18 posterior and needs to be 10 anterior. So she's 28 degrees off. That's a huge rotational. That's like 30-degree rotational deformity. That's like your foot sticks out 30 degrees, you know? So that's why her knee is bothering her, because she's trying to pull her foot straight and it's jamming her hip, right? And to plan the correction, I do my mechanical axis. See, it's a little more than the other side. So maybe I'll correct a little bit of varus. And I want to correct that sagittal deformity to just get her knee extended a little bit so that she gets that full extension back. So I'll plan an integrate nail. The majority of my correction is rotation, but I'm also fixing a little bit of sagittal plane and fixing mechanical axis. So it's really important to take sagittal into and rotation into account. And the CT version is a really good way of doing it. Here's a cool PDFA, right? Posterior distal femoral angle. So here's a patient who comes in, leg length discrepancy. Oh yeah, and her knee doesn't quite go straight. She didn't even really recognize that was a problem. But when I just watched her walk, she couldn't get her knee straight. So it turned out she's a flexion deformity. And if you can't just say she got a knee flexion contracture, go to PT. Because if you do the analysis, you see that she actually has a growth plate injury that not only made her 4 centimeters shorter, but it also flexed her femur, right? So it's subtle. The X-ray it's not that obvious, but if you measure it, then you'll see that her PDFA is supposed to be 83. It's actually 70. And then you can take that into your consideration. And her tibia was normal. So for the analysis, again, for leg lengths, we do direct and indirect. They're almost the same at about 40. She had a little bit of external rotation deformity. Her deformity is at the knee joint, so I need to do my osteotomy at the knee joint, right? Like, what can I just do the retrograde nail and extend this? Well, nails aren't very good at fixing flexion. They create flexion problems. They don't fix them. So it's better just to fix this with a plate, right? So I do an opening wedge posterior extension osteotomy to correct the flexion deformity, and then rotation and length are done separately through the proximal femur. And then it's the other part of this the other part of this is super important is the physical exam, right? So not only do you have the CT version studies and you have your radiographic measurements, but physical exam is super important when you're looking at, what do I really want to fix, right? So that's a functional measurement. And here's, lay the person prone. You can do internal external rotation of the hip. You can look at their thigh foot axis.